Value-based care at a conceptual level is simple to understand and it makes complete sense. Better outcomes at a lower total cost of care. But as soon as you scratch the surface, it suddenly gets complicated, really complicated. In real life, the concept of value-based care is implemented as a value-based contract. A contract which is between the payer and the accountable care organization, also called the ACO. Now, these contracts, they use quality measures to measure health outcomes. And this is because directly measuring health outcomes often takes decades, and no one wants to wait that long to find out if they saved any money. Also, it is very hard to predict the future cost of care as it involves a lot of fancy math that actuaries do. This predicted future cost of care is called the benchmark. So essentially, the ACO needs to beat this benchmark to show that they saved money. But here's the secret. All math is based on inputs into a model. Garbage in is equal garbage out. Choose the wrong inputs and the outputs are completely wrong. And guess what? These benchmarks can easily be manipulated by changing the inputs. For example, make the patients look sicker and suddenly the benchmark goes up and magically value-based care saved some non-existent money. Now, if all of this sounds confusing, believe me, we haven't even scratched the surface yet. In order to try to explain what is really going on in these value-based contracts, I created a financial simulation model that mimics these contracts. My goal is to show you that value-based care is a high-stakes game of financial engineering, and the vast majority of time, independent ACOs with independent doctors will go bankrupt within a decade, which then leads to consolidation, which then increases the total cost of care, the exact opposite of what value-based care was designed to achieve. In this video, I'm going to walk you through the basics of the value-based contract using the model that I created. And then, if you want to play with the model yourself, you can find it on vbcsim.pcplens.com. All right, let's dive in. Okay, so when you go to vbcsim.pcplens.com, this is the webpage that you're going to see. And right on the top, you can see that this entire simulation is divided into 7 steps. And each step has some instructions on the top, which tells you what you can do on that particular step. So obviously, the first step is we need to configure the ACO. And we're going to be looking at a lot of variables across all of these steps. So to make life easier for people who might not be that familiar with the mechanics of ACOs, I created 3 different scenarios, worst case, realistic, and best case, for you to just kind of start with playing with it till you understand some of the basic mechanics, and then you can go back and you can start changing the variables and then looking at the outcomes. For the purpose of this video, we're going to keep it as under the realistic scenario. Now, the first thing when you're setting up an ACO is you need primary care physicians. And the story that I had or I created was, like in most places in this particular region, the total cost of care is going up and the payers want to try to figure out what they can do to reduce the total cost of care. So they go to a large PCP group and talk to them about forming an ACO and sharing some of the money that they can save and reducing the total cost of care. The large ACO group bands together, figures out all the other independent ACOs, brings them together and forms an ACO. The next step is how many patients does each individual PCP has. And again, over here, I've modeled it about 1,000 patients per PCP, but again, you can change the sliders back and forth. The next step is the attribution percentage. Now, the attribution percentage is always going to be lower than the patient panel that the PCP has. And this is because of multiple reasons, but the biggest one is probably what's called the payer mix index, which means that of all the insurances that the PCP might be accepting, only a few of those insurances might be in the value-based care contract. So if I'm accepting 10 insurances and only 5 of them are in a value-based care contract, maybe only half of my patients are in a value-based care contract. And in that case, I would change the attribution slider to about 50%. So this allows you to play with the model and how many attributed patients you have. And again, there are tooltips everywhere. So if you can see the tooltip over here, which explains what many of these variables mean. Let's move down. Next is financial parameters. So the first one is the annual total cost of care. And in our case, we've selected at $10,000. Next one is target savings that both the payers and the ACO is going to try to achieve to decrease the total cost of care. In this case, we've selected the target savings about 5%. Next is what's called the minimum savings rate, which is that the ACO needs to achieve this before the payer is going to give them any money. The reason, as far as I understand, the minimum savings rate exists is to protect the insurance companies, because it is hard to project the actual total cost of care. So the insurance companies really want to hedge against, if they got some of the math wrong, they don't want to pay something out when the math was wrong and you really didn't reduce the total cost of care. So that was the intent of the minimum savings rate. But again, it's designed to protect the payers, not the physicians. Next is the ACO shared savings percentage. This is essentially of, if you end up saving the money, how much of that is going to be retained by the physicians and how much of that is going to be retained by the payer. And a lot of times it's 50-50, so that's why I modeled it as 50%, but again, different contracts can have different terms. Next step is quality. The first thing is the quality gate. Many ACOs or many payers will ask the ACO to hit a minimum quality gate before there's going to be any money that's going to get distributed, even if they reduce the total cost of care. The reason for this is to get around the whole HMO era in the 1980s, 1990s, when the payers were found to be denying care in order to raise money. So this kind of tries to do that, but it really throws PCPs under the bus, that now you need to hit a bunch of quality metrics, which I've kind of written about in my previous articles and why they really don't measure quality, but that's the purpose of this. The next step is what's the ACO starting quality score. And in this case, I've modeled it out as 82% to give the ACO an advantage. Now, typically, especially for independent ACOs with independent practices on multiple different EHRs, this becomes a data collection issue. So the starting quality score for independent docs on multiple different EHRs is generally a lot lower. And again, I modeled this down the road, so I'll show you what happens when the ACO cannot hit the quality measure. And then the last one is the risk adjustment score. Risk adjustment factor is essentially telling the payers, how sick are my patients, and if my patients are sicker, you need to give me a higher benchmark. And it's not only just the ACO starting risk adjustment factor score, it's also the regional benchmark. Because what the payer is saying is, I want to see how sick are your patients in your ACO, and I want to compare it with the region, because I need to figure out how much money I'm going to allot for the entire region, not just for your ACO. So if your patients are sicker, definitely I'll give you more money, but if your region, other ACOs are more sicker, have more sicker patients, they need more money, and then you can get penalized. So what this really shows is that the HCC coding game is essentially rigged. If your region has a higher HCC score or risk adjustment factor score, your ACO has a lot of catching up to do, because you are going to get a really low benchmark. So with our initial selection, this is what we have. We have about 80,000 attributed patients, and we have about 800 million in the total cost of care. With that, we can move on to the opportunity cost, or to see what the opportunity is. Now, for people who really understand all of these mechanics and you want to jump directly to the Monte Carlo simulation, I provided a link right here at the bottom. You can just click this and you can bypass all the steps and go directly to the Monte Carlo simulation. And all the variables that you're going to see in the first 6 steps are also available in the Monte Carlo simulation if you just want to jump directly to it. All right, with that, let's go to the next step, see the opportunity. Okay, step 2, the opportunity, what I also call the pot of gold. So let's look at the math quickly. We have about 100,000 patients, 80% attribution rate, which means there is about 80,000 total attributed patients to the ACO. Since each patient costs about $10,000, the total number of attributed total cost of care for the ACO is about $800 million. Of the $800 million, there's approximately, you need to save 5%, and assuming you hit your target of 5% savings, that's about $40 million. Now, since there is a gain share of 50-50, the payer keeps 50%, the ACO gets 50%, the ACO will get about $20 million if the ACO succeeds. So, and if there are 100 physicians in the ACO, each physician gets about $200,000. So the pot of gold opportunity is each physician has the ability to make an extra $200,000. And again, That's a huge amount of money. I could probably hire a nurse, probably another staff member to be able to take care of my patients. But that is the opportunity that is presented. That was also the initial thought process when the ACOs were being formed, that it is a way to direct money into primary care so that primary care would be able to hire more staffing, be able to put processes in place so that you can take care of patients. But we'll see what happens to this pot of gold opportunity in the next few slides. So the ACO, which was formed with the 100 PCPs, now they have a board and they look at this pot of gold opportunity and they unanimously vote to proceed to sign the VBC contracts. Now, reality sets in. So let's go to the next step. Now that the board has voted to proceed to form the ACO and you're signing the contract, reality sets in because we need infrastructure to run the ACO. So let's look at some of the infrastructure costs. You need data and analytics, and again, assuming in this case $450,000. You need care managers. There's care manager salary. There is a lot of administrative staff. You need a CEO, you need contracting people, you need medical directors, you need other staff to be able to run the ACO, and all of that costs a lot of money. You need IT and EHR integration, assuming that these are multiple different physicians and multiple different EHRs. How are you going to bring all of that data in? And that costs money. You need legal and compliance costs because you're going to be dealing with a lot of healthcare data. Next is quality reporting. Again, you have multiple different EHRs. Somebody needs to collect all of that data, package it, and then send it to the insurance companies to prove that you're actually doing the work. And all of these things, they cost money. And again, if you don't know what some of these are, there are several tooltips which explain what these variables do. And again, you can adjust the sliders to whatever you want. The next thing now is the per PCP burden. This is something that we don't capture. When a primary care physician moves from a pure fee-for-service model into a value-based care model, it comes with opportunity costs. There are expectations that you have to do more in a value-based care contract. So because of the expectation that you have to do more, primary care physicians now have less time to see patients because they're doing a lot of this administrative tasks. And these administrative tasks can be you're meeting with the care managers, you have ACO meetings with the ACO leadership that you need to meet. You might be collecting data for a submission of quality measures. So a lot of these things that you have to do, that takes away time. In our case, we are assuming that this is about 3 hours time per week that the PCPs who would be able to see patients now are taking that time out from seeing patients and doing the value-based care administrative tasks. And then for those 3 hours, there's a fee-for-service cost. So let's assume there's $100 per visit under fee-for-service that the PCP was making. And if they're losing 3 hours per week, and if they have 3 visits per hour, 3 hours per week, that is a substantial amount of money that the PCPs are losing because they are just doing all of these VBC administrative tasks. Now, in addition to the primary care physician doing some of these VBC administrative tasks, you also need some of the staff members also have tasks that they need to do. And so you have to allocate additional staffing in your office per PCP to be able to carry out some of these tasks. And so over here, I've modeled out 0.25 FTE per PCP and then the practice staff salary. And all of that adds up. And as you can see, actually, let's go back. So the ACO infrastructure total cost based on what we discussed before was about $2 to $2.1 million. And the per PCP practice burden is about $57,000 to $58,000. So not only do you have the ACO infrastructure cost that you need to worry about, but every single PCP, there is an opportunity cost of about $57,000 to $58,000 that they're foregoing in order to be able to do or participate in value-based care. Now, the other thing is once you sign the ACO contract, let's say it goes from January to December, you are not going to see any shared savings for another 6 months. And that's because of a multitude of reasons. Predominantly claims run out by the time a patient is seen, let's say on December 31st, and the claim is put in and the insurance company runs the claim and it's all calculated. It's about 6 to 9 months. In our model, we are just saying it's about 6 months. So what that really means is before any reconciliation is done, before any decision is made to give the money to the ACO and to the physicians, they have to bear the cost for at least 18 months. So that $2 to $2.1 million for 18 months becomes about $3.1 million. The ACO has a burn rate per month of about $174,000 to $175,000. And by 18 months, the PCPs have already lost about $86,000 in opportunity cost by not seeing patients. And this is not just affecting the primary care physician because they're losing money. It's also affecting the patients because now the primary care physicians have less time to see patients, and then this reduces access. So there's more downstream consequences from spending time on administrative tasks instead of seeing patients. And we're not even talking about burnout from having to do a lot of these administrative tasks. So these are just pure monetary figures that we're modeling out. So I hope this makes sense. Now, you have the $3.1 million that the ACO needs in order to run. Where are you going to get that money? You need somebody to fund it. And that's our next step, where you need to choose your funder. All right, so let's move to the next step. Okay, so now we have about $3.1 million that we need for 18 months, and we need to find a funder. I've taken 4 different funding sources in the model. The first one is your bank loan, followed by hospital, payer advance in what's called a per member per month, and also private equity. So 4 different funders that we can choose from. And they all have the different trade-offs, and I've listed some of them over here. If you scroll down, you can choose which funding model you want. And once you choose the funding model, it opens up a subset of variables now that you can adjust. So in case of the bank loan, you can see that there's an interest rate, there is loan term in months, and there's an origination fee. And all of this will add to the cost that the ACO needs to repay the bank. If we scroll down and we select, let's say, the hospital partner, the hospital will ask you to form what's called a physician-hospital organization as a clinically integrated network so that you can go in and sign a contract with the payers. This physician-hospital organization, or PHO, if they are funding the ACO infrastructure, they are going to ask for something in return. And this typically happens in the form of 2 things. The first one is that they're going to ask some portion of the gain share. So in the example, if you're still following the pot of gold money, if the ACO ended up saving $40 million, 20 million of those, the payer will keep it, 20 million comes to the ACO. And if the hospital is taking 50% of that, out of that 20 million, 10 million is going to go to the hospital and 10 million goes to the physicians. In addition to asking for some gain share, most of these hospitals will also ask for referrals. So for the independent physicians to start redirecting a percentage of the referrals to the hospital employed specialists or the hospital emergency room or to the hospital for procedures. Now, generally hospitals, just by virtue that they are larger, they probably have better fee-for-service contracts with the payers, which is what forms your hospital cost premium. Just because you have redirected a lot of these patients from independent specialists, which were a lower site of care or lower cost of care site, to a hospital system, which is a higher cost site of care, you have suddenly spent a lot more money. So if we assume, based on some of the variables that we've chosen, that our total referral volume is about 240 million, which out of that about 144 million gets locked to the hospital, that's about $31.7 million. That's just a 22% hospital premium cost. That wipes away a lot of your savings because you are now forced to refer patients to the hospital, and it makes it very, very hard to succeed in an ACO, especially in partnership with the hospital. And again, we'll see how this affects a little bit later. Actually, I'll probably end up doing a different video with the hospital. I'll just follow the bank loan. So let me go back up and select bank loan, and then we're going to move forward to the next step and see, and the next step is outcome. So we're going to see how this affects when the money is reconciled in 18 months. All right. Okay, moment of truth. Now let's look at the outcomes. 18 months is up. I've modeled 3 different outcomes over here: TCOC miss, quality miss, and the hit target. So let's see if we miss the total cost of care. In this case, I've modeled out, let's say the ACO only saved 1% and the minimum savings rate was 1.5%. In this case, even though the ACO 1% savings was about $8 million, because they missed the minimum savings rate threshold, which was $12 million, the ACO gets $0. The payer, assuming that their calculations were correct, they get to keep that $8 million. So in this case, our ACO share is 0. The loan has accumulated because of the interest, it's now $3.6 million. Since in our model, every PCP signed that they are personally responsible for that loan, every single PCP is responsible for about $36,000 because there's 100 PCPs. And PCPs also had an opportunity cost, which lost them another $86,000. So if you add all of that up, it comes out to about $122,000. And that's a lot of money, enough to bankrupt many primary care physician practices. And this is one of the reasons why you see consolidation, because a lot of these primary care physicians, they cannot maintain their practice losing $122,000 and they end up selling to a larger organization. Okay, now let's look at the quality miss. Initially, we had favored the ACO that the ACO would be able to hit quality target of 82% and the quality gate is 80%. But in this case, let's just say that the quality score for the ACO when it was reconciled came out to be 70%, required gate was 80%, and so the ACO is going to get $0. In this case, let's assume that the ACO actually hit their cost target, which means that they did end up saving $40 million. So the ACO was supposed to get $20 million, but because the ACO did not hit their did not hit their quality metric, the $20 million that the payer was going to keep, they keep that, but they also keep the $20 million that they were supposed to pay out to the ACO, they get to keep that too. So the payer keeps the entire profit of $40 million. So you can see why payers might want to use a quality gate, because it becomes a negotiating tactic. If you raise the quality gate, even if the ACO reduces the total cost of care, the payers still end up keeping all the profits. This is why contractual terms are way more important for the ACO success than what we as primary care physicians do in the office. And again, as I've said multiple times in the past, when you have multiple individual practices, a lot of times meeting quality measure targets is about data collection. It's not about actually taking care of people that is better for them. All right, let's move to the next one. Let's say if we hit the target. So 5% savings rate equals $40 million. Payer share is about $20 million and the ACO gets $20 million. Now, obviously the ACO needs something to keep for the next year of operations. So there's going to be a little bit for the operations retention. They also are going to keep something in reserve. And then there's also the loan that has to be paid out. So you have to subtract all of this from the ACO share before it gets distributed to the physicians. So the net to PCPs in this case ends up being $14.6 million, which ends up being about $146,000 per PCP. Sounds great. Lot of money, $146,000. But let's do a little bit of reconciliation. Let's deduct the opportunity cost, which is about $86,000. And suddenly, now it's about $60,000 that actually came to PCPs. Still a fair chunk of money, but nowhere near the pot of gold of $200,000 that the board voted for in step 2. So as you can see, what gets promised under ACO, under these contracts, very little of it actually ends up making to the primary care physician in order to put processes in place if you really want to help patients. And again, there's still the loan which is outstanding, which needs to be paid for the subsequent years, and there's the loan term which is still outstanding. So I hope this makes sense for year 1 reconciliation. Now let's move and try to project it forward several years. And so we'll go to the next step. Now, assuming that the ACO succeeded in the first year, let's try to project this out to multiple years. And this is where the ACO mechanics start getting even more complicated, and we're going to introduce a lot more variables. I've tried to explain some of them over here, but also I have a lot of tooltips to try to explain what they are. But let's walk them through one by one. So the first one obviously is your projection scope. So in this case, we are modeling out 10 years. Next is looking at the contracts and benchmarks. So our target savings rate remains the same, our minimum savings rate remains the same, but we're introducing a new concept called the benchmark ratcheting. What this essentially means is that if in the first year you saved some money and you reduce the total cost of care, whatever you saved, that gets baked into your next year's total cost of care. So if we started off with the total cost of care as $800 million, and let's say we saved $10 million, next year our benchmark is going to be $790 million. So as the benchmark keeps getting ratcheted down, the opportunity to decrease the total cost of care also reduces, which means eventually there is going to be a point where the ACO is no longer going to be able to decrease the total cost of care and will fail. So this is one of the things which becomes a huge point of negotiation in many of these contracts. Is there going to be a benchmark ratcheting or not? Next is going to be the risk adjustment. And again, the first few are the same. You still have the ACO starting RAF and the regional market RAF. But now we also have the annual risk adjustment factor growth percentage. What this is essentially saying is once you have an ACO, the ACO is going to put processes in place to appropriately code the patients and make them look as sick as they are. And so your risk adjustment RAF score is going to increase year over year. And in our case, we are modeling it at about 5% growth per year. So as the RAF score increases, our benchmark increases. However, we not only have to worry about our own ACO's RAF score increasing, we also have to look at what are the other ACOs in the region doing. How quickly is their RAF score growing? And in our case, we modeled it at 3%. After a few years, you can only make patients look so much sicker. So eventually you're going to hit a point where you can no longer make patients look sicker because you've already coded all the appropriate conditions. And so you hit a ceiling. And so the RAF optimized by year is just telling you to choose which year you're going to hit that ceiling. The next one after that is RAF growth after optimization. And this is essentially saying that even after you hit your RAF ceiling, some people, just by virtue of time getting older, are going to get sicker. And so your RAF score is still going to keep increasing, but a lot more slowly. So this is what this is modeling, and we've set it at to 1% over here. Next is a coding intensity cap. The coding intensity cap is something that a lot of payers, including Medicare, has in place, in which if an ACO suddenly increases their RAF score by a huge amount, the CMS is actually going to penalize them and going to say like, oh yeah, you increased your RAF score by 5%. Nope, you can only increase by 3% because suddenly you're going to get a windfall in shared savings because your benchmark is going to be a lot higher. So this is designed to sort of kind of prevent upcoding, if you will. And the last one is the regional RAF also saturates, which means that if your ACO is going to hit the RAF saturation that you've already optimized your risk adjustment so much, your region is also going to kind of, after 3 or 4 years, they're also going to hit the same ceiling. All right, next one is the quality dynamics. Again, the quality gate required in quality score is from our first page, where your quality gate is about 80% and the starting quality score is about 82%. Now, as part of the ACO contracts, because the quality score is required, the ACO is going to try to put in place mechanisms to improve the quality measurement. And so the next one, the ACO quality improvement pace, is modeling by how many percentage points can the ACO improve the quality every year. And in our case, we've selected that at 3%. Also, the payers every year are going to ask for higher and higher quality thresholds. And this quality gate ratchet is just telling the contractual mechanism on every year how harder it is going to get to hit the quality measure. So if we select 2%, year 1 it was 80%, next year the quality gate is going to become 82%, year 3 it's going to become 84%, 86%, and so on. The next two are the maximum achievable quality gate, which is, in spite of doing everything, the ACO, this is where you can, the quality gate that you can achieve, you can go no further because it's hard to hit 100% quality essentially. And then the quality gate ceiling is also giving payers the benefit of the doubt because they realize that the ACOs cannot hit 100% quality gate. They are not going to ask ACOs to achieve more than a certain amount in terms of quality gate ceiling. And again, there's multiple tooltips for all of these to explain what these mean. Let's move to the next one, that's inflation and growth. So inflation absolutely will come into play, and so we have to select what our annual inflation rate is and to what is it going to apply. In the base model, I've only selected apply inflation to ACO expenses and to PCP burden. We can choose if you want to apply the inflation also to benchmark, and then if you want to apply it before or after the ratcheting for the benchmark takes place. And again, you can look at the tooltip and it explains what it is. So leaving all the defaults in place, the ACO with all of these defaults in the realistic scenario will actually end up failing by year 9. So let's look at the financial view, and this is the table that I created under the financial view. So the first year we had said that it's $800 million you need to save, and the ACO was able to share $20 million and you hit. But as the ratcheting happened for the benchmark, look at what happens. You are no longer able to hit your 5% savings, but you're still making more than your minimum savings threshold. So you're getting some partial hits. And the ACO continues surviving with some partial hits till year 6. And in year 7, they end up missing the total cost of care because the benchmark has been ratcheted down so much. However, the ACO is still able to survive for the next couple of years because they had put some money away in reserves till they hit year 9 when the ACO fails, because now they don't have any more money left in reserves. So this is kind of a model showing you what happens if you project our variables out for about 10 years. So our 10-year summary is the total net that was distributed to PCPs was about $51.6 million. Years with payout was 6 out of 10 years. Net after burden was about negative $9.7 million. So even if you think about, oh my God, the PCPs got $51.6 million, but once you add on the opportunity cost, the PCPs are still at a loss. An average per year loss for PCPs in this case is $11,000. And again, this is taking over 10 years, right? So you're also including some of the years that the ACOs were participating in the contract till the ACO goes bankrupt. So you model all of that out, and the ACOs are on average, the PCPs on average have lost about $11,000 per year. So that was looking at the financial view. Now let's look at the quality view. This is pretty simple because we've set the system or the model to always hit the quality measure. So that's what essentially saying. So if you end up changing the parameters that the ACO fails, if they're not able to hit the quality measure, then that's going to show up in this table. It's going to show you when the ACO starts or does not hit the quality measures and when they fail. All right, so I hope this makes sense. And again, the summary still remains the same because in our case, the ACO is unable to meet the obligations in year 9 and they end up losing money with about an $11,000 loss per primary care physician. So I hope this makes sense. Up until now, everything that we've discussed is based on what we as the user are selecting as variables. Next, we are going to move into what's called a Monte Carlo simulation, which allows us to randomize many of these variables. So what's a Monte Carlo analysis? This is essentially a way to stress test the different variables. For example, if you want to do an analysis to see what happens if we change the quality gate by a certain percentage, what happens if we change the risk adjustment factor by a certain percentage, and you can try to do this yourself multiple times to see what the outcomes could be. But what Monte Carlo does is it allows you to automate that process. So essentially, you can hold some variables constant and you can randomize the other variables and you can run that simulation thousands of times, and Monte Carlo simulation gives you a probability analysis to tells you based on the 1,000 times that we ran the simulation model and with the different variables that we've randomized, what would your probability of outcomes be? So that's a simple way to explain what a Monte Carlo simulation is. In our case, what we are doing is the Monte Carlo simulation, it randomizes your starting first year variables because it's extremely complicated to randomize every year. So we're just randomizing the first year and then we project it out for multiple years. So I hope that makes sense. And if you click on how it works, it actually gives you some of the information on how I've structured the model over here. The next thing on this page is, this page has all the variables that we've encountered before because I wanted to give people the opportunity to be able to hold some variables constant while randomizing others and look at the outcomes. So you still have your worst case, realistic, and best case scenarios. You still have your funding path that you choose. And then you have all your different parameters. So you can choose which ones you want to randomize, which ones you want to hold constant. So I can check this if I want to hold this interest rate constant versus uncheck it if I want to randomize it. Now, as a default, what I have done is some parameters that are quote unquote, they're part of the contract, I have held them constant, while others are being randomized. But again, you have the option, you want to uncheck all of these and randomize the whole, you can do that. Or so it just gives you the option of which ones you want to randomize. So you have bank loan, network and market, which was the PCP count attribution, contract terms, and you can open all of these sections to see which ones are being randomized and which ones are being held constant. Once you've made the decision on what you want randomized and which ones you want held constant, the next is you want how many, under the simulation settings, how many iterations you want it to run. In this case, we are running about 1,000 simulations, but you can have more simulations for it to do the probability analysis. The next one is the variation range. So what this essentially is doing is telling you, based on the worst case, best case, realistic case scenario, if whatever the attribute was chosen, it's going to, in our case, going to model it 50% on each side. So for example, let's say our ACO quality score over here is about 82%, right? If I randomize this, it is going to use 82% as the starting value and is going to randomize it 50% to the left side and 50% to the right side to try to figure out what the probability analysis is. Next is the distribution type. You can have a uniform spread or you can have what's called a realistic spread or a triangular spread. The difference between this is when you are modeling 50% on each side of the chosen variable, uniform spread will sample across the entire width of that attribute or of that variable, if you will. What realistic spread does is it'll actually choose more variables around what the chosen one. So let's go back to our ACO starting quality, which was 82%. Under realistic spread model, when it's randomizing, it's going to choose more values around 82%. And as you get further and further away from 82%, the number of values that get chosen for randomization starts decreasing. So this is designed to, the reason why it's called a realistic spread is most of the time, your spread in randomization, it's actually going to be closer to what your previous year's performance was, and there's not going to be huge jumps. But again, it gives people a flair of like whichever way they want to randomize. I wanted to give people that option. Once you're done selecting all of this, then you can decide to run the simulation. So let's run the year one simulation and see what happens. Year one, 100% of the ACOs survive. You have about mean $20.3 million that the ACO receives in shared savings. The probability of ACO loss was 0% and the 5% and 95% probability of shared savings is listed over here. It calculates that out. You scroll down and then you see a nice graph of the probability of distribution and how much money the ACO is going to get across all the different probability outcomes. Lower down, there is a sensitivity analysis, or what's also called a tornado chart. It tells you which of the variables have the most effect in terms of success or failure of the ACO. In our case, the deterministic model, which gives us more of the dollar figures, we can see the starting total cost of care has the highest effect in making sure if we get shared savings or not. So if you're already starting off with a population that is pretty well optimized and is a lower cost of care, your opportunities for success dramatically decreases. And obviously the second one after the total cost of care per patient is how many patients do you have? So this really shows that this value-based care is a scale game. The higher number of patients you have and the sicker they are, hopefully the more money that you can save in a value-based care contract. The next one is a correlation analysis, and again it shows you that the total cost of care has a very high correlation with success or failure on an ACO. Okay. Now we saw what happens to shared savings for the ACO. Now let's look at what happens to per PCP when they participate in this model in year one. Again, the year hit rate was about 100%, but let's look at it. the probability loss for primary care physicians is about 20%. The worst 5% probability is about they lose $47,000, and the best case is that they actually gain $155,000 in the first year. And again, if you scroll down, it shows you the distribution per PCP net income in terms of a distribution graph. All right, now let's go and let's run the multi-year simulation model. So once you hit the multi-year simulation model, now you also have a new box that you can select for how many years do you want to run the multi-year simulation model. Now again, let me reiterate, when at least in the model that I've created, when you're running the multi-year simulation model, it is only randomizing the variables for the first year, and then it is projecting that out. So you randomize it about 1,000 times for the first year, and those 1,000 different outcomes for the first year are projected out for the next 10 years in this case, and then it gives you the distribution of the outcomes. So I hope that makes sense. Okay, let's run the multi-year simulation. Look at this. ACO survival rate based on the parameters in 10 years is only about 25%. 75% of the ACOs will generally end up failing. Again, it shows you the mean money that's the ACOs earn over those 10 years. Again, the average failure rate for ACOs in this case is about 6 years. And this again shows you the 5% and 95% probability loss. This shows you the cumulative shared savings over time, assuming that the ACO continues to succeed. This shows you the ACO survival rate as the years pass. The ACO survival continues to keep decreasing, and this is the distribution, probability distribution of the financial shared savings that the ACO gets. And as you can see, as the years pass by, the shared savings becomes less and less and less. You now again have the outcome probability by year. You know, what is your hit rate by different years? What's your how many years you hit partial, and then the cumulative failure rate. We go down, and now again we have the sensitivity analysis for the 10 years, and now you can see what's making the biggest difference. What others are doing in the market. What's your regional risk adjustment factor? So if you are in a market and you're the only ACO and you have optimized your risk adjustment, and the other physicians are not doing a good job of risk adjusting, that is your highest likelihood of achieving more shared savings. Obviously, the next one is what are you doing in terms of increasing your risk adjustment? So if your ACO is aggressively risk adjusting patients, that's your next one that increases the probability of your shared savings. And then again, you have the familiar total cost of care, which impacts your shared savings. So you have that, and then again, you can click the correlation, and then you can see which ones are correlated with shared savings. And interestingly, over here, it shows the quality gate ratchet. So the faster the payer ratchets up the quality gate, it actually leads to higher failure rates for the ACO. Now, we looked at what happens to the ACO. Now let's look at the per PCP net for 10 years. So everything remains the same, but look at the PCP profit rate is about 43.6%. Mean is what they make is about 15,000, median 33,000. Probability of ACO loss, even though the ACO might have succeeded, the probability of PCP loss is about 56%, and they lose anywhere about $440,000, and they make about $780,000 depending on this modeling. And again, this is the cumulative per PCP net, what they make in profits over time. This is again your ACO survival rate. This is the probability distribution of what your PCPs make. And again, this is the same outcome probability by year. And you have the same sensitivity analysis that I'm doing. So you can see when you run the model and you project it out for 5, 10, 15, 20 years, just based on how the ACO is structured, a lot of these ACOs will end up failing. So based on the model, I hope I've convinced you that the contractual mechanics actually play a much bigger role in ensuring if an ACO succeeds or it fails. It has a lot less to do with me as an individual physician, what I can do in my practice for the ACO to succeed. So that's how these ACO contracts are structured, value-based care contracts are structured. They don't have anything to do with care per se. All they have to do is figuring out which contractual mechanics you can tweak in order to get gain share, and then you have a middle management layer that ends up taking a portion of these gain share, and very little of it ends up reaching the primary care physician. The other thing is, when we talk about value-based care improving the actual care that's delivered to the patient, it's actually the opposite. What ends up happening is Now I am wasting my time on a lot of these administrative tasks that I have to do to prove that I'm actually taking care of patients. I was already taking care of blood pressure. I was already taking care of diabetes. I was already doing, quote unquote, what people think as preventive care. But now I have to prove every single thing in order to get any gain shared savings, and that reduces the total amount of time that I have to actually see patients. And if I have less time to see patients, I have fewer patients that I can see, and now I've created access issues where patients they don't have enough primary care physicians that they can get in to see them when they fall sick or when their blood pressure rises or something else happens. Next, what happens is eventually, since all these independent ACOs are going to fail unless the contractual mechanics are really changed, a lot of these primary care physicians, they go bankrupt or they throw their hands up and say, like, I'm not dealing with this, and go and join a large hospital. When that happens, the total cost of care goes up because of consolidation. These large organizations, now they go to the payer and say, well, last year Aetna, I had 500 providers, physicians. This year I have 600. So I need you to give me a higher rate, because if you don't, we're going to go out of network and your patients will not have a place to go. And that increases the total cost of care. So you've created access issues. You've created consolidation, which increases the total cost of care. So what are we really getting out of value-based care? Now, some people are going to come back and say, let's take the example of Aledade. Let's take the example of another ACO. They're doing great things. They're saving so much money. They're improving the total quality of care. And that's true. There are some stars, some people who are doing a really good job. But I would even argue that even in some of these ACOs that they're really doing a good job, a lot of the mechanics of, quote unquote, improving the quality of care is actually related to the social determinants of health. For a lot of these patients in whom quality of care increased, they didn't have transportation to see their PCP. They couldn't afford their medications. That is why they were using the hospital, right? So if you start you start removing these socioeconomic barriers, obviously the total cost of care is going to decrease, because now these patients are getting care in a lower cost setting, and their hypertension, diabetes, blood pressure is being managed much better because they're not going to the emergency room. But these are socioeconomic issues. So essentially what value-based care is doing is trying to push a lot of these socioeconomic issues to primary care physicians. And a lot of primary care physicians are throwing their hands up and saying, like, I don't want to deal with this. I'm going to go become employed. So that's kind of a summary of, hopefully, what I was able to convince you based on the model. The model is available on vbcsim.pcplens.com. There will be an accompanying article on pcplens.com that explains some of the things that I went through in this video. If you find an error in the model, or if you have suggestions for improvement, please leave me a comment on pcplens.com. I will read it. I promise I will read it. And if I can improve the code, I will try my best to improve the code. I'm not a coder. This was all vibe coded using Claude Code and OpenAI Codex, but I do want to make the model better, make it more usable for people. So if you do have suggestions, please do leave me a comment. With this, take care. Goodbye.